welcome to Family Medicine Grand Rounds. I know we have several sites that are on remotely, and we thank you for joining us as well. Remember, if you are here at the med school, sign in so you can get the CME credit. If you're on remotely and can do a sign-in sheet, that would be great, and then you could email that to Jenny, JENNY.Wilka, WILKA, at usd.edu, so you can receive the CME credit as well. We want to thank the SDAFP, Avera, and Sanford for their support of Family Medicine Grand Rounds. And if you want to mark your calendar, the next Family Medicine Grand Rounds is Thursday, June 6th at 12:15, and we'll have a USPSTF update at that time from a former member of the USPSTF. So again, that's June 6th at 12:15. Our speakers for today are going to be discussing point-of-care ultrasound, and they are Dr. Brad Kampstra. He is a board-certified family physician and a member of the Sioux Falls Family Medicine Residency faculty. Prior to his faculty position, he practiced for 15 years in Rock Valley, Iowa. He attended Kansas City University College of Osteopathic Medicine for medical school and completed residency in Sioux City, Iowa. He is a member of the faculty as an assistant professor with the USD Sanford School of Medicine as well. A special interest of his is physician burnout. He serves on the Light Committee at Avera, which works to provide the support and tools needed to help reduce stress, improve work-life balance, and prevent burnout. He also has other teaching interests, including faculty for advanced trauma life support, and most recently learning and educating about point-of-care ultrasound. Our other speaker is Dr. Roy Mortensen. He is a board-certified family physician and has been practicing in the emergency department in Vermillion, South Dakota for the last 8 years. Dr. Mortensen finished his undergraduate and medical school at USD in Vermillion. He completed his family medicine residency in Grand Forks, North Dakota, and then moved to Vermillion to practice family medicine in 2002. He switched to doing emergency medicine in 2010. Dr. Mortensen has a passion for teaching medical students. Since 2002, he has taught Introduction to Clinical Medicine, Clinical Foundations of Medicine to both first and second year medical students, and he currently serves as a director for Clinical Foundations of Medicine course. He also teaches advanced trauma life support to physicians and advanced practice providers, and he is a retired lieutenant colonel from the Army National Guard with 2 deployments. Let's thank Dr. Kampstra and Dr. Mortensen.
Thank you. All right, well, thank you. And first disclosure, probably more than anything, is by no means, and I think I can speak for Dr. Mortensen, is we don't claim to be experts in ultrasound by any means, but as family physicians, we feel like this is important because of where medicine is going with technology, as well as just where teaching is going, and just where we see medicine going at this point. So I'm not going to go through a lot of detail at all on the objectives. You've probably read them. That way we can kind of get through this information. There's several different things we want to talk about today related to point-of-care ultrasound. I think a lot of people are become very familiar with what point-of-care ultrasound is, but just to help identify this so that we're all on the same page is that there's a lot of terms maybe you've heard or maybe read in the literature, but even in magazines, newspaper articles, you'll see things like bedside ultrasound, maybe limited ultrasound or focused, goal-directed. All of them kind of mean pretty much the same thing, and we use it now, our term that we like to say is point-of-care ultrasound, where we abbreviate everything in medicine, so we call it POCUS. And really it's an exam that's performed at the bedside simultaneously with your clinical exam. It's not something we're trying to get out, you go out of the exam room, you grab your machine, bring it right back in, just as if you grab your stethoscope. Really best described as an extension of the palpating hand. If you're doing like an abdominal exam, you just have the probe in your hand to do the rest of your exam. It just becomes a deeper exam. Usually there's no formal interpretation other than what you've interpreted of what you've seen. And right now, the way we have it, and we'll go into this a little bit more about, even retaining images. And there's some discussion that needs to happen on how we document as well as save those images. This is done in a clinical setting, all of our offices. Highly used right now in the emergency departments, in the hospital, especially the ICU. This has been a very significant adjunct in diagnosing and treating patients. For years, family physicians have been doing this in obstetrics, where we're doing position of baby, maybe we're doing a dating ultrasound, an anatomic survey. It's been pretty standard for most family medicine residents to be learning that. And also, now we're starting to also use it in places where there's limited resources, whether it's populations like a federally qualified health center, where we can decrease costs without having them to go to the hospital for something that we have pretty good idea, but we just want to be reassured that we can use an ultrasound for that. But also, many physicians are going to do international type work, and you can use it there where they don't have any resources to do these evaluations. I like this picture because I think it kind of really exemplifies what I see this turning into sometime down the road here, if it's not already in some medical school and residency settings, where you have a machine that fits right into the side pocket with a probe and be able to just pull it right out just like as if you pulled out your stethoscope. So we'll quickly touch a little bit of the advantages, disadvantages. Obviously, the cost can be significantly less than if you're concerned about some problem that you may have with their complaints or your physical exam findings. But maybe an ultrasound would be an easy way to make that diagnosis without having to send them for a CAT scan or MRI. Really pretty quick and easy to perform, especially if you have it readily available in your pocket or even right down the hall from your office where you're seeing these patients. Machines are in widespread use due to their cost, and so to get them and their maintenance is significantly less cost than trying to maintain some of the higher end machines that we use for diagnostic purposes. There's no radiation, so there's no increased risk. Example I think of right away is somebody who might have a kidney stone and repeated kidney stones. They come in with a lot of pain. Instead of repeating a CAT scan on them all the time, there's different ways that we can evaluate that to see if they've got hydronephrosis, if there's other problems that we could identify much easier with much less exposure. And of course, the size, I think, is really the defining part of it now. As technology improves, we are able to put them right into our hand from the big box machine that they had a difficult time rolling down some of the hospital hallways. And so you can bring it right into your outpatient clinical exam as well as the emergency departments. This was just some information that I thought really helped to show the cost savings. And this was really looking at the cost of evaluating just rotator cuff injuries and ankle injuries. And a lot of these people maybe had a pretty good idea that they had a rotator cuff injury, but most of the time what do? We jump right to an MRI. Same with an ankle injury that's more than just acute. Really we can identify some of those tendinous structures, some of the muscle structures with an ultrasound for both of those joints and probably save not only some time but significant cost. And so they projected that Medicare costs could be saved like almost $7 million within the time frame of 2006 to 2020. And so significant change, and it really probably is going to help in managing your patient, and probably more conservatively, which most of them would be anyways. Some of the indications when we look really at what we're going to do with point-of-care ultrasound, resuscitative. It can be used looking at hypovolemia, a pneumothorax. These diagnoses can be made really quickly, and so you can intervene just that much quicker. Even more diagnostically, looking at pericardial effusions, pleural effusions, and procedures, paracentesis and thoracentesis. We can look at joint aspirations. Maybe there's an abscess or foreign bodies. Dr. Mortenson's going to go into that a little bit more. Musculoskeletal injections therapeutically has become a real mainstay for family medicine. And so typically we're not going to order an ultrasound to be done formally on some sort of musculoskeletal structure, but we can just evaluate that and maybe even treat that right at that point. Regional anesthesia, even just an assessment of an organ. If you're worried about somebody who has mono, look at their liver and spleen. Their cardiac, the abdomen, multiple organs that we can evaluate, and even just vascular status if we're looking maybe see a DVT. Obstetrics, we're already kind of doing that, but even urgently if we're worried about an abruption, if we're concerned that maybe there's some sort of other problem related to an early pregnancy, if there's a tubal pregnancy and they're bleeding or having a lot of pain, we can make that diagnosis much quicker and to wait for an ultrasound tech and see if they're available. And when I was in a small town, to get that tech, it might be 2 or 3 hours away. I had to send that patient to Sioux Falls. So you're putting them on a flight, doing all kinds of other interventions that could have saved that cost. Emergency, we'll talk about the FAST exam. Even screening, a lot of screening tests that we do, stroke screenings where we look at a lot of the vascular structures, abdominal aneurysm, even just a quick LV function of your heart, and again, the DVT. Certainly there's disadvantages that we see and certainly have to think about as we consider this. And certainly as we all learn, we learn at different levels and can understand it better. And some people can really have that good eye-hand coordination, which becomes part of learning this process. So it's really user dependent. But just like everything else that we learn, the more you use it, the more you try to train your eye and your hand of looking at this, you get better at it. Certainly there might be limited field of view. A whole CAT scan, you can do the whole abdomen and get almost all those structures. With the ultrasound, it's limited to where the images that you're looking at right at that time with that probe and in that plane. But you can keep moving it around in a lot of different directions just to get that evaluations. Especially obese patients are going to be much more difficult for the ultrasound waves to get through a lot of that adipose tissue, not only subcutaneously, but maybe they've got a lot of intra-abdominal issues there too, and even thoracic. And then even some of the deeper structures might be a little more difficult to identify. But as our technology is improving, certainly the wavelengths and the probes are picking that up more and the clarity is improving. Certainly we're unable to penetrate air, bone, and other things that have a reflection off of it. That's just the physics behind ultrasound. Maybe the environment that you're in could somehow limit that. Now, if you're in an ER, you've got a big trauma, you've got tubes, you've got all kinds of things that are in that environment at that time. I think of times where maybe if there's dirt, somebody's coming off a farm accident or something, certainly all of those things in that environment can have a limitation. How sterile do you keep it? How do you keep the machine clean? Become part of that. But more and more as we're seeing how point-of-care ultrasound is being used, the military is even using it on the field to make their assessments at that point. So they are finding ways that can be done in a reasonable way. And then, of course, regard to the spatial tissue resolution compared to a CT, MRI, something you have to take into consideration as you're looking at different images. This is where I kind of foresee how this looks like in our clinic. How do we do this? It's just that simple to have a machine that's not very big. You can just set things right up and you're ready to go. I'm going to turn this over to Dr. Mortensen.
Yes, I'll talk a little bit about the fundamentals of the point-of-care ultrasound. And really, it's best described as an extension of that palpating hand. So we want to look at it as if it's our stethoscope. It's not necessarily any different than that, but this stethoscope has so many more abilities to figure out what's going on, and you're way more accurate, I think, with it than you are even with your stethoscope. You might need to gain experience with it, but like your stethoscope, gaining experience takes time. We need to step away from thinking about ultrasound as this traditional diagnostic test where we order it and they have a checklist of images they do and measurements they need to take and what have you, and look at it actually being a point-of-care test where we're answering a specific question, like if you were going to guaiac a stool or you're going to do a blood sugar. You know, those point-of-care tests, this is what we're looking at as well. You know, does the patient have blood in their belly or gallstones or cellulitis or abscess? These are quick, easy questions to answer, and you can do it right at the bedside. And there's usually no formal interpretation. It's just the person that's doing it, their interpretation of it. And it certainly can be used to complement the physical exam and enhance the diagnostic capabilities or accuracy, and I'll go over some of that. It certainly has increased dramatically in the last few years. A good question is why? Ultrasound's been out there for a long time. Well, the advances in technology, as you can see with some of the ultrasound machines we have in the rooms here, they are much smaller, more portable. Usually they're run on batteries, cheaper. The expense now of the ultrasound machines, even our nice one over there, is certainly come down quite a bit. But a $3,000 to $5,000 ultrasound machine is going to get you something that has at least 2 probes and you can do basic stuff on. You think about if you were a pianist or a violinist or some person that plays a musical instrument and you were a doctorate at that level, how much would you pay for that musical instrument that you're playing? And realistically, I see people eventually buying their own and carrying it around with them and using it, becoming more familiar with that instrument and being a lot better with it. You can go on Amazon right now and buy your V-Scan, so it's kind of interesting. They're smarter. They're much easier to use. You can have the presets where it sets the optimal gain and depth for you. We've got an ultrasound machine over there that actually goes over a video on how to do certain exams. So if you forgot where to put the probe, what angle to get, what have you, it literally will walk you through it, and you can do it at the same time at the other screen as you're looking at the actual patient. Better images, higher quality images now than we've ever had on other ultrasound machines before. We're talking about this black and white, gray, what have you. Well, now these images are so much better. And it makes it a lot easier to learn, too, especially if you have a really nice instrument or a nice tool. You can make out those images a lot better than we have in the past. The second big reason why now is there's a lot of evidence out there that says this is a good thing and we should be doing this. A large body of evidence demonstrates that bedside ultrasound improves clinical outcomes, facilitates more rapid diagnosis, shortens time to definitive treatment, reduces failure and complications related during procedures, and improves patient satisfaction. Well, that's huge. There's nothing in medicine in the last 200 years that hasn't come out that could have this type of impact, and we should really be excited about this and get behind it and learn more about it and start using it. The third big reason is American Academy of Family Practice is also behind this. I made a couple of copies, but this is their resolution from 2016, increasing the point-of-care ultrasound education, and this is for the family medicine residency program, saying that they need to incorporate that into their curriculum. So you might not have learned ultrasound in your residency program, but in 3 years it's going to be standard of care for them. They'll know it. It's a part of their curriculum now. So encouraging every family physician residency program to have a curriculum with the point-of-care ultrasound, offering POCUS or point-of-care ultrasound, CME programs. I don't know if many have gone to them or not. They fill up quickly, so if you do go to them, you want to make sure you put your name in quickly. But the AFP has also resolved to increase its continuing professional development opportunities and faculty development programs regarding the point-of-care ultrasound at its annual meetings and continuing medical education. So that's one of the biggest problems we have is our faculty aren't trained. They graduated medical school. They didn't have this technology to play with at that point in time. Now the med students are playing with it and the residents are playing with it, and they're much better than the attendings out there. The attendings don't feel comfortable with it. So we got to get to a point where we can bridge this gap, bring everyone up to speed on their continuing medical education. And I've got a couple ways to actually hopefully address that even locally here, and one of them is this piece of paper that you might have picked up when you're out there. So some of the basics again in ultrasound. Most ultrasound machines will have this curvilinear probe. Several of them will have a the straight probe or the superficial probe. And then for cardiac and a lot of other exams, this probe is what you'll want and what you'll need. If you're looking at getting an ultrasound and what probes you need, there's like 20 to choose from. These are the 3 probes you need. The superficial, the curvilinear, and the cardiac probe is kind of what we call them. Modes, we can talk a little bit about that. The B mode is the brightest, and that's what you use when you just turn it on. The M mode, it really determines movement, and you can go side by side with 2 images to see movement on there. We do that frequently when we go through the FAST exam and checking for pneumothorax. The Doppler effect, a lot of the cheaper ultrasound machines, the $5,000 ones, what have you, they're not going to have Doppler effect to it. You've got to step up to the 20,000 or something like that to get the Doppler effect on it. But you're going to want that because the Doppler effect really helps you out figuring out certain things like direction of flow, velocity waves, even the power Doppler. If you're looking at maybe a testicular torsion, it really detects flow to that area, or ovarian torsion, it really detects flow to that area. So it is nice to certainly have, and if you're looking at getting an ultrasound, I'd certainly look for that Doppler mode. How it's used today? Well, here's a classic example. You got a 22-year-old male that comes to your ED in a motor vehicle accident, and he has abdominal pain. His blood pressure's kind of on the borderline. His heart rate's a little fast. What do? Got to figure out what's going on in his belly. You send him over to CAT scan or not. And these 2 ultrasounds really should help demonstrate. There's fluid on one side in Morrison's pouch. That liver is above the kidney. Most people can see that. And on the other side, there's no fluid, at least yet. You can always repeat ultrasound and find out. Make sure the vitals are stable before you send someone over to CAT scan, where if you ever work the ER, you know that that's where all the bad stuff happens, usually. So that helps you figure out what you need to do with this patient quickly and hopefully avoid complications. The FAST exam has been well proven to be beneficial, and it's kind of become the standard of care in trauma. And when Brad and I teach ATLS, you'll find that the 10th edition now has images on there that you need to be able to identify as far as stuff happening. And there is even a breakout group to do the FAST exam. So that's coming if you haven't researched your ATLS. How else it's used? We got a 21-year-old female, right upper quadrant abdominal pain, white counts normal, liver functions normal, beta HCG normal. You get a CAT scan or ultrasound. Well, can you get an ultrasound? In my facility, my ultrasound tech kind of works 9 to 5. So that almost takes it out of the equation. Oh, you know it's a gallbladder. We'll just do it in the morning. They have to be fasting anyway or what have you. You kind of want to know what's going on with this patient. Is it an emergency or not? And usually when you talk to your attendings, if you're a resident, the chief complaint is abdominal pain. The next thing that comes out is say, what did the CAT scan show? So maybe we can reduce radiation and stuff by using this bedside ultrasound to figure it out. You know, this is a good example where you actually see gallstones. So you might feel comfortable just studying them for the diagnostic test, that ultrasound in the morning, to look at it a little more thoroughly. Maybe you can avoid that radiation that night. Here's another one, a 34-year-old female, red-hot tender mosquito bite. She says she's got about 5 or 6 days ago. Is it cellulitis or is it an abscess? How many have poked an 11 blade through to see if they can drain anything out, and it's a dry tap? They get nothing. Now they got a little scar there too that you made. Wouldn't it be nice if you could just put the ultrasound on, and if you see this big bag of fluid there, you know there's something underneath there to drain, versus this kind of cobblestone appearance of the edema, swelling, and the adipose tissue of a cellulitis. And that doesn't take a whole lot of training to figure this out. You know, you could literally Google it or play with it online and figure out if you need to do something with that. So here's another one. This is an excellent one. We've got a 22-year-old male comes in with a puncture wound on his hand. He was hiking. He had a stick. He jabbed it in there. He's pretty sure he's got something in there. It was 2 days ago. He says it feels kind of tender still. I think there's something still in there. You feel it. Yeah, you know, there is some swelling there, but you're not sure where exactly it is. And The ultrasound just makes it so much easier. Even wood, you know, you can get an x-ray of this, but it's not going to show. Or how many have got an x-ray of glass somewhere or a BB somewhere, and how do you find it? How do you get it out? Well, with this, you can literally put your numbing lidocaine needle right where the tip of that foreign body's at, leave it there, take the syringe off, what have you, and follow your needle down the foreign body. So it makes it so much easier to actually do stuff and improve patient care. You can actually take care of them at the time. Tough IVs. Oh my goodness. Just this alone should be something that most people would be interested in if they've ever tried to get a young kid or an adult that was difficult to get an IV in, to get therapy going. You know, here the nurses do this. You know, the nurses are trained to do this. I think we should at least be trained enough to do it. When you're in rural medicine, when the nurse can't get the IV, guess who they turn to? And you know, last time I did that was in, you know, in the residency program or even in medical school. And in medical school now, we don't even start IVs on each other. We use this plastic arm that has 20 different holes poked in it already, and it's, you know, not necessarily the training that I think we should do. But all right, other uses. There are so many. You know, you think about how you use your stethoscope and you carry that around like it's a religious thing. But there are so many things you can use your ultrasound for. Dyspnea, you know, is it COPD or congestive heart failure, the clue exam, A lines, B lines, we could talk about that. The pneumothorax, abdominal pain, abdominal aortic aneurysms, screening for abdominal aortic aneurysms. We're going to have a USPSF presenter come, and, you know, we are really bad at this. We're less than 50% for sure of getting those people from 65 to 75 smokers to get their screening exam. And how hard would it be if your electronic medical record said, oh, you need this, let's just do it now. Lay back, I'll take a look and see. Check that off. So it would certainly improve patient care. DVT, you know, like my facility, do I call in my tech, which, you know, probably not going to come. Oh, let him wait until tomorrow. I had a great example where I thought it was a Baker's cyst that ruptured, but his cousin on his wife's side, just like you're not even related, had a blood clot, and that's what he's worried about. He had this sudden onset of swelling, and he thinks there's a blood clot going on. There's big bruising and what have you. So you get your D-dimer, it's positive because he's got this, I think, a Baker's cyst that had ruptured, but he's convinced it's a blood clot. So do you send him home on a little Xarelto and get the ultrasound in the morning? Well, the Xarelto might make it bleed more back there, might make it worse, more swelling, and might eventually get a blood clot just because of the swelling and pressure on that. But you can do a 2-point ultrasound point-of-care test to rule out a DVT in 95% of your patients. Most of us know that a DVT from the popliteal region up are the big ones that cause PEs and they die and what have you. But you can get one of the common femoral and popliteal area, and with a 95% chance, you know that there is no blood clot or PE there. So you can certainly treat based upon that. And that's an easy one to do. It doesn't take a lot of time to figure out. Renal colic. This is another excellent one. You've got your 44-year-old male that comes in for the 5th or 6th time this year. He's had 5 CAT scans. He's got kidney stones. You know he's got kidney stones. He's got blood in his urine, but he always has blood in his urine. He wants his Vicodin because he's got another one. You'd kind of like to have some imaging to say, yeah, he's got a kidney stone, but you can use hydronephrosis as that imaging. So if there's a question about those narcotics that you're using or what have you, you can certainly use this to help out. Evaluation of hypotension, we've covered a little bit of that. Ocular trauma. Many people don't realize that the eye itself is pretty easy to ultrasound. You put a piece of Tegaderm over it, you can put the gel right on there, and you can see the back of the eye, you can see the lens, if they had some lens that was off or what have you after surgery, cataract surgery. Retinal detachments are pretty easy to see with the ultrasound. If you do that, though, you want to make sure you peel the stuff off to the side, not to the other eye. When you get the gel in your eye, it does hurt, by the way. Musculoskeletal. This is a really fast-growing use of ultrasound. You know, it's certainly something that we see a lot of musculoskeletal injuries, and if you can ultrasound it and figure out what's going on, you know, you're going to improve your skills as well as tell that patient exactly what the problem is. And injections, of course, are much easier if you can see exactly where the anatomy is at and where to put it. Anatomy itself. This is where our medical students come in. You know, this picture used to be we would be dissecting a cadaver here, but now they're ultrasounding to figure out their anatomy. And this is where they're learning it. They're learning it at the same time they're learning their anatomy and the physical exam of that section. So the training process for medical students. In 2014, 62% of the medical schools had a curriculum, you know, all three pillars. The 38% we were a part of. We did not have a curriculum at that point in time. The last few years I've at least established a curriculum for Pillar 1, and Pillar 2 and 3 are still in the works. I wonder what this number is now, 2019. I couldn't find anything out there, but I'm willing to bet more medical schools are embracing the ultrasound training. They're taught anatomy and the physical exam right at the same time over the specific body part, how the ultrasound is used to visualize the anatomy to assess for pathology. And again, it's used as an extension of the physical exam, not a diagnostic tool. So we need to get away from the diagnostic tool and get more towards using it as a part of the physical exam. Pillar 1, we have a great introduction lecture. Dr. Pfeiffer does that for us and covers a lot of stuff. Then we go into head and neck, and we look at the thyroid, and we look at the veins, and we look at the eye. And heart we cover. We have them use the cardiac probe, looking at the heart, chambers, the valves, the lungs. We can go over multiple things with them there, including the lung slide of pneumothorax, the diaphragm, and how it's supposed to move, or whether they've got a pleural effusion or not. A lines and B lines. Everyone remembers B lines on a chest X-ray with congestive heart failure. Well, the same thing with ultrasound. So you can actually detect that as well. You kind of say, well, how do you do that? And you know, there's air in the lung. We actually use the artifacts of the air in the lung to help with that, to detect that. So. Abdominal exam, you know, the big things there, the gallbladder, liver, spleen. We're looking at the abdominal aorta. So our med students will be able to find that for you. If you're not sure how to do it, they'll find it for you. And measuring is something that they get tested on in their OSCEs now. So they will be able to know how to use the caliper and find those things out. Musculoskeletal, again, we do shoulder and leg and wrist. It's pretty impressive if you have an impingement syndrome to have someone actually do that, and you can see the tendons moving and see it impinge. So that's the nice part about ultrasound, is it's in motion. You can literally see things moving. If you want to inject the carpal tunnel and you want to make sure you get it close to the nerve, have them wiggle their fingers. You can see those flexor tendons move, but that honeycomb nerve sticks out pretty easily. Pillar 2 and 3, the curriculum's still in development. It's kind of rotation or specialty dependent, and it really depends upon the attending you're with. But it's getting a lot better, and we're getting a lot more use of it. So, and it's kind of becoming more expected too, that the students can start to use it and be able to use it. Our challenges, though, obviously, is we don't have enough attendings out there that are comfortable with it, and good access to high-quality machines. It is so much easier to learn on a really nice machine. That's why the ultrasound techs use the nice, big, expensive ones. If you try to learn on a little V-scan where the screen is about that big and then your wedge is like that big and the pixels you can fit into that, it really makes that screen harder to make out. So I think the smallest I would go if you're learning would be a laptop screen. Try to get the pixels there so it's at least easier enough for you to make out the images. All right, so in 1824 I found this. I thought this was actually a pretty interesting quote. Like most new technology, there's a risk that the new practitioner will make mistakes based upon their erroneous interpretation. This technology, therefore, must be restricted. Does anyone know what they were talking about at that time? Any guess? Yeah, stethoscope. Yep. So, let's go back to you, Brad.
All right. So, again, we talked about some of the disadvantages, but really want to kind of cover some of the challenges that we're facing. And Dr. Mortensen kind of already touched on the medical school aspect, but again, we're moving into the residency areas. But more and more, all the different specialties are really embracing the ultrasound. And so that's almost becoming an expectation of all their different boards and their academies that are really looking to make that happen. But as he said, to getting the attendings training to be comfortable with it, not only for their patients, but also if they're precepting medical students and residents. There's many that are interested, and some are even more reserved. So this past fall, I went to the AAFP conference, and I'm involved with a members interest group of a lot of people doing this. And we had a lunchtime, and the biggest concern that came up is how do I learn this, but also costs and all these things of documentation and how good do I have to be. And so there are real questions that some of them still need to be answered, but we're still working on that. The advanced practice professionals are all doing this and learning this in all the different specialty areas. Even the EMTs and paramedics are learning how to use this in all their different settings. So we need to develop those methods of ongoing mentorship, coaching different people, kind of starting with some of us that have gone to these different conferences, and then developing them through that training. Competency always becomes a big deal, especially when you're looking at hospital boards and clinic quality things that come up. Who determines who's competent in this? How many different areas do I need to scan and feel comfortable with that? And do I need to be certified? There's multiple areas out there if you look on the websites, that people that will certify you to do ultrasounds. Well, that certification really is, if you want to be really good at gallbladder ultrasounds, you can get certified to do that. It's not really what we're talking about. This is right at the point of care where you make an interpretation at that time of how you're going to move forward with your decision making. Now, some of the curriculum that's established has already given some guidelines for total scans for all of point of care would be someplace in the 150 to 300 scans. I just think of that with our residents, to get that many scans in 3 years with all the other things that they're doing and learning is a lot of scans to be not only done by each of our residents, which we have 30 of right now, but also who's going to overread them. But sometimes some people say, well, I just want to learn specific areas. And so some of the recommendations, anywhere between 25 and 50 of that specific area. And then even like the ultrasound guided procedures is someplace between 5 and 10 of each procedure. Some of that seems a little overwhelming to try to get to that point to feel competent at that. And I feel that it's really something that we just become more and more comfortable with. And you're probably still going to order the ultrasound, a formal ultrasound on the gallbladder. But over time, if you start to use it, you become more familiar with what you're seeing. You see the reports come back that maybe confirms or goes against what your interpretation might be. That's how you're developing your own competency also. And many of the different specialties are out there that are trying to come up with what does that look like. And that's kind of where it stands now. I think that will change. What about credentialing? I know the hospitals are looking at this and have already put things in place for sure at the emergency department level. But even for those ER-trained docs, sometimes it's even hard for them to get all of these different scans in. FAST is probably the most common one that they're going to be using, so they get proficient at it. All the way back in '99, the AMA had a resolution that said that they want ultrasound to be part of the scope of practice and left the training to each specialty. The AAFP just passed this resolution that Dr. Mortensen talked about. Then, of course, it comes down to documentation. How do I document what I did? Well, I don't really see it right now. If you're using it in the bedside, in the clinic, or in the hospital, in the ER, it's part of your examination, right? So you've done your head-to-toe exam, and then a lot of times you'll probably document what you saw in a chest x-ray or maybe part of your lab. This is where that information is going to go, and it's usually just your interpretation of that. Now, if you want more of a formal procedure note, that's probably something where you've done like when we do a dating ultrasound or an anatomic survey. You've done specific criteria to determine some sort of diagnosis or wherever you're at on that scan. And then you make a more of a formal note. That has to be separate outside of the progress note. But you're also charging for that a lot differently. And so then how do we charge for these? Do you charge for just an informal view? And then you got to document for it. So it is part of the exam. How do you do that? Do you charge to use your stethoscope? Not right now, but it is part of your exam. But there's different levels of your examination also. If you're just looking for a foreign body versus gallstone versus a AAA, there are some CPT codes that are set up and established to be using in the clinical setting that are separate from a formal ultrasound. But it has to be documented within your progress note. There is reimbursement from insurances and CMS requirements that go with that. We have that established through the Sonosite with the AFP has actually laid those out. What if I just use that handheld machine? I just pull it out of my pocket, take a quick look, make a quick documentation, and you just move on. Again, it's part of the care of that patient that you can make and establish at that point of care to be able to continue to move on. Just make a simple documentation of what your interpretation of that scan that you did at that time. So the CPT codes are being developed. Some of them are already there. Now, a lot of times if you're going to do some sort of charging with an informal or a formal, you have to be able to document your findings, not only what you interpreted, but to have a live or some sort of image that is stored, whether it's within your EMR or what we do is we save it to a jump drive. But it has to be secure, but it also has to be retrievable. Outcomes for improving care, obviously this is why we do this. But we need to know and look at more ways of how do we measure this. And there's a lot of things that we can do, and cost seems to be the most common one. But I think as we do this more and more, we're starting to see better outcomes for patient. We're able to make that diagnosis quicker, and those costs will go down. So we're just finding different ways to even look at how we measure that. Patient perception is a big deal in this. You're putting your hand on that patient even more. You're looking deeper into their anatomic structures, so they feel like you're doing more of a formal evaluation. So they perceive that you're doing more for them. And I think even more so down the road, this will be probably publicized, in all of our media, and this will be an expectation that patients will want and say, well, you should just do an ultrasound. So-and-so got this, and they had that. And so I think the patients will want that. Certainly liability always becomes a big concern besides those costs. Making those documentations is a big thing. What about things that we might miss that we maybe had stored on an image? What about unintentional findings? I think of the thyroid gland. You're just doing a quick scan of the thyroid, or maybe you're looking at the carotids and you find this big nodule that maybe you didn't feel on a palpation. How do we move forward with those unintentional findings? And then when do you send for a formal evaluation? I think that answer is if you're not comfortable with what you see or you feel like you need more information, you always send it for more of a formal evaluation. Costs for ultrasound is a big hurdle, especially for smaller clinics to really look at. Costs come in training, and we want to get more people trained. Well, Well, some of these courses can be very expensive. You have to take time away from practice, away from family. You got the travel costs. Some of these ultrasound courses are very expensive because you need, standardized patients, the equipment, all of those things that are involved with that. Even just buying the machines. Now, the handheld machines, roughly $4,000. They are getting cheaper. Some of the basic machines, I have an invoice that we just looked at here when we bought some of the machines for the School of Medicine, and it's dated December of 2013. The machine that we're using at that time was just over $7,000. Well, now that we're at 2019, it's about $5,000. So those costs are coming down. A really good machine where you get better quality, good Doppler, all the different things that you can see better are probably around $50,000. And so it's a big budget item. Again, but we have to try to continue to look at where we're saving costs at the end. And how can we capture that back? Also, the probes. Probes are very sensitive. You can't drop them. They break. Those piezoelectric crystals are very sensitive. Over time, they probably do wear out. They get dirty. And you can't always clean some of that. Over time, that becomes a problem if you're using them more and more. Each probe right now is $1,500 to $2,000 a piece. What about maintenance? You got to keep up on maintenance. And then storing images. You want it a secure place that's HIPAA compliant. It takes a lot of space, especially if you're doing it on some sort of server. So you got to think about those costs. To kind of look at, why we do this and try to really look at this, there's a lot of advantages, and I think this is just the way we need to be looking at how we not only teach medicine, but how we look at treating and evaluating patients. Now, this was something that I found that I thought was really pretty unique. This actually came out just July of 18. This was from one of the doctors up in Minneapolis. The following are lessons I have learned since becoming interested in point-of-care ultrasound. This guy is 70 years old, and age is not a barrier to becoming a point-of-care ultrasound expert. But an end-of-career physician must have the passion for the skill and be able to spend the time to learn and practice this. It's part of his desire in medicine. One of our faculty, he's one of our oldest faculty, going to be retiring. He's one of our experts in ultrasound. A potential point-of-care ultrasound physician should enjoy the technology. It should be something that you really want to, really do that and possess a steady hand, good coordination. It's just fine motor skills. I think if we're doing a lot of procedural things, the hand-eye coordination continues to improve as you get used to it and know what you're doing. The financial issues certainly need to be dealt with before equipment is purchased and training is initiated. So that's just being stewardly about how we look at this. But when the barriers are overcome, a robust point-of-care ultrasound training is complete. There are better outcomes, there's lower costs, and I think even, as I think about from my perspective, just knowing a lot about burnout and satisfaction, he hit really hard there, a great physician satisfaction. So I kind of spun off some of the terms we use, a final resolution, so we are all on the same wavelength for point-of-care ultrasound. It is a newest adaptation of technology for the future of medicine. It does improve patient safety and outcomes. Multiple studies out there that have documented that. Its portability makes it quick and easy to use. Its overall cost to patient can be decreased to their overall costs in their evaluation. Also supporting resource-poor settings, I think, is very invaluable. Most specialties have pretty much embraced this, and this can be part of their learning in medical schools as well as the residencies in their curriculum. And it just adds a whole new dimension to the exam room. You've got your interaction with your patient, you've done your exam, but it kind of takes it to the next level. And so it is new and it's exciting, not only for the patient, but I think even just for the physicians. Somebody like myself who has been doing this for 15 to 20 years, just adds just that much more. It's kind of fun, it's something new, and something more that we can do to help that patient. And again, I think patients certainly appreciate that we can do this. So I do see that point-of-care ultrasound is the wave of the future. And so I think that as we move forward, it's something we need to continue to try to educate and just embrace, that we continue to try to make it a standard of care in in the hospitals and clinics or more. Thank you.
We have time for a couple questions, and actually, if anybody wants to stay, Dr. Kampscher and Dr. Mortensen are willing to experiment, play around with the ultrasound equipment that we have in the room.
Are there certain conferences that you have found to be the most helpful? Like, oh, this is just a great 2-day kind of update as to the potential uses and comfort with the
So
process.
if you didn't hear the question, those that are out there, is there certain conferences that really are better than others? And I think, there's multiple out there, and I think all of them are getting to the point of really showing the basics, especially of multiple areas. So there's a lot of those that are out there and really getting pretty good at it. Like the joint injection that I did at the AFP was really good. The basic one I did about 2 years ago at the Institute in South Carolina was really good. And those guys really have a established curriculum, not only for their students, but their residents at multiple levels, as well as their mission is to train people well. But there's more and more coming up all the time from different schools, different regions, and I think a lot of people that have gotten really good at it and feel that passion are doing that. So.
If you are interested, Spocus.com is a great website. They list a lot of CMEs, so if you want to look at that, or just Google it, you can certainly find it there. The FMX, Family Medicine Big Meeting, they always have 3 or 4 CMEs there to go to as well. They do a great job of that as well as their national meeting.
So have you found that if you find gallstones using this ultrasound, will a surgeon act on that, or do they still want?
Yes. You want to answer that, or you want me
Yeah,
to?
the question is, will a surgeon go ahead and move forward with a cholecystectomy after finding gallstones on a symptomatic patient? And I think probably right now they might be a little bit hesitant, but at the same time, I think it depends on their clinical picture. If they're running fever, they've got elevated liver enzymes, their white count's up. It certainly looks like an acute cholecystitis, and you have a document of gallstones and maybe an inflammation of that gallbladder wall. I think more surgeons might be more comfortable with that. Can I answer that for them? Of course not. They may still want a formal one before they take them to the OR, but I think if they have enough data, I would say the similar, appendicitis. Your exam and your history tell you about appendicitis, but do they need the CT? Some surgeons are very comfortable with just what you find on their exam, and so.
I personally have found they always want the diagnostic test, and some of them actually want a CAT scan on top of that.
Oh.
So it seems like it. I'm not sure if they're up to speed with it or not. Some of them, but just 2 weeks ago, I had one that came and wanted a diagnostic test. 2 hours later, wanted a CAT scan because the pain was more epigastric and maybe a little in the left side. So it must be something else. But ended up with the gallbladder.